All right, let's dive into something pretty incredible today. We're going to peel back the curtain on the hidden electrical grid that powers your arm, that amazing network of nerves that turns a thought into an action in, well, less than the blink of an eye.
I mean, seriously, think about it for a second. Grabbing your morning coffee feels totally automatic, doesn't it? But underneath the surface, there's this lightning-fast chain of commands firing from your brain down your spine and zipping right into your arm. And really, the best way to picture it is as a kind of biological superhighway. It's this complex bundle of wires carrying every single signal you need for movement and for feeling. It's the command and control for everything from a powerful high five to something as delicate as threading a needle.
And just like any big electrical grid, one single point of failure, a pinched wire, a cut connection, can cause a total blackout in one part of the system. That's exactly what a nerve injury is. And if we want to understand what goes wrong, we first have to understand the grid itself. So where does this all begin? Well, it all starts at a central junction box, you could say, a command center for the entire arm. And that's known as the brachial plexus. This is the origin point, the power station for all the wiring we're about to map out. So next up, we're going to look at how this network is actually put together. And let me tell you, it's a brilliant piece of biological engineering where just a few main power lines branch out from the spine to create this incredibly sophisticated distribution grid for your whole arm.
Okay, so what's so amazing is just how elegantly this thing is built. It all starts with just 5 nerve roots that pop out from the spinal cord in your neck. Then these roots merge together to form 3 trunks. Those trunks then split into divisions, which then recombine into 3 cords, and finally, these cords are what give off the major nerves that go down to the arm. The big takeaway here is how this whole super complex system all starts from just 5 simple points. It's fantastic.
So once that network is all set up, it really boils down to 3 major power lines, 3 main nerves that travel all the way down the arm. And here's the cool part. If you can get a handle on these 3 main nerves, you basically understand 90% of how your arm and hand are controlled. And here they are, the big 3. First, you've got the radial nerve. It's in charge of extension, straightening out your wrist and fingers. Then there's the median nerve. This one's all about bending and gripping. It's your power nerve. And finally, the ulnar nerve, which is all about fine motor control, those little intricate movements of your fingers. And as you can see, each one has a very distinct, very obvious sign when it gets injured. We'll get to those in just a bit. To make this even easier, let's just give them nicknames. Let's call the radial nerve the straightener. We'll call the median nerve the gripper. And the ulnar nerve, that's our fine-tuner. Trust me, if you keep these in mind, understanding the injuries becomes so much easier. Okay, so now that we've got the layout of the grid, let's talk about what happens when things go wrong. Let's explore what these power outages in the arm's electrical system actually look like. A major outage can happen right at the source, at that main junction box we talked about, the brachial plexus. This usually happens from some kind of traumatic injury where the head and the shoulder are pulled apart really forcefully, which can stretch or even tear those initial nerve roots. And what's really fascinating here is how the direction of the injury totally changes the outcome. So if the force pulls your head and shoulder apart, like in a nasty fall, you damage the upper roots. That leads to something called Erb's palsy, where the arm hangs in this classic waiter's tip position. But if the force yanks your arm up and away from your body, like if you grab a branch to stop yourself from falling, you damage the lower roots, causing Klumpy's injury, which mostly messes with your hand. But hey, the power outage doesn't have to happen at the main junction box. Sometimes it happens further down the line, affecting just one of our 3 main wires, the straightener, the gripper, or the fine-tuner. So what happens when our straightener, the radial nerve, goes offline? You get this classic sign called wrist drop. The muscles that are supposed to lift your wrist and fingers just lose power, and your hand just hangs. You literally cannot straighten it out. And this really shows you just how vulnerable these nerves can be. Wrist drop can be caused by something as simple as pressure from crutches pushing into your armpit, or even just falling asleep with your arm draped over the back of a chair, which is famously known as Saturday night palsy. Now let's talk about the gripper, the median nerve. When this one fails, you lose power to those big, fleshy muscles right at the base of your thumb. And over time, those muscles just waste away. Crucially, you lose the ability to bring your thumb across your palm to touch your other fingers. That's called opposition. This one single failure just devastates your ability to grip anything, and it creates this very characteristic flattened look known as ape hand. And finally, we have our fine tuner, the ulnar nerve. When it gets damaged, the little tiny muscles inside your hand that it controls get really weak. This creates an imbalance, right? The stronger muscles in your forearm overpower these weakened hand muscles, and they pull your fourth and fifth fingers into that classic claw hand shape. This is actually pretty common in cyclists from leaning on their handlebars for too long. They even call it handlebar neuropathy. So let's zoom back out for a second and just appreciate this entire system. This is the body electric. It's this beautifully designed, intricate network that we rely on every single second of every day, usually without even giving it a single thought. And it all comes back to that core idea. From just 5 simple nerve roots, this entire intricate system emerges. It's a system that has the bandwidth to control both the raw power you need to throw a baseball and the incredible delicacy you need to play a violin. It performs flawlessly, millions of times a day, for our entire lives. Which kind of leads to one final thought. When you see just how much we lose when a single one of these wires is cut, it really makes you appreciate the profound importance and maybe the fragility of every single connection. What's the real cost of just one broken wire? Thanks for tuning in.
Welcome to the deep dive. Today we are strapping on the headlamp, so to speak, and heading deep into the human body's wiring. Specifically, the nervous system pathways that control our arms and legs. We've got some pretty dense anatomical source material here, but our mission is really to simplify this complex network. We want to understand the brachial plexus and, what happens when these crucial wires get damaged. It can be surprisingly dramatic.
Absolutely. And what's really fascinating, I think, is how directly this anatomy translates to clinical practice. The sources hammer this home. Knowing the location, the specific nerve roots like C5 down to T1 for the arm, that's the key. It helps you predict what you'll see in a patient. It's the difference between, say, a completely useless limb and a very specific issue like ape hand. So, clarity on structure and injury patterns, that's the goal today.
Okay, let's start with that foundation then, the brachial plexus. You described it as the wiring for the whole arm. It sounds like the major hub connecting the spinal cord out to the limb. We hear these terms, C5, C6, C7, C8, T1. What are those exactly?
Right. So those labels, C5 to T1, they refer to the actual nerve roots exiting the spinal cord. C is for cervical vertebrae, T for thoracic. So the fifth cervical down to the first thoracic spinal nerve. And they matter immensely because basically every muscle, every patch of skin in your arm gets its instructions from one or more of these specific roots.
Got it. So these 5 roots pop out of the spine, and then what? They don't just run straight down the arm, do they? It sounds more like they merge and split.
Exactly. They weave together. It's a very systematic structure. Think of it in levels. First, you have the roots, those C5 to T1 segments we just mentioned. Then these roots merge to form 3 trunks. The upper trunk from C5, C6, the middle trunk, just C7, and the lower trunk from C8, T1.
Okay, roots to trunks. Makes sense. What happens after the trunks? You mentioned splitting.
That's the next level, divisions.
Right.
This is where things get functionally interesting. Each of those 3 trunks splits into 2 divisions, an anterior one and a posterior one. And anatomically, this split happens right behind your collarbone, the clavicle, about midway along it.
Okay, and why split? Is there a purpose to anterior versus posterior?
Definitely. Generally speaking, the anterior divisions will carry signals for the muscles on the front of your arm, think biceps, the muscles that bend things, the flexors. And the posterior divisions, they're heading for the muscles on the back, the extensors, like your triceps, that straighten things out.
Ah, okay. So the wiring is already getting sorted by function. That helps visualize it. And after divisions?
After divisions, they recombine again to form the cords. There are three: the posterior cord, the medial cord, and the lateral cord. These cords are named based on their relationship to a major artery in the armpit, the axillary artery. And it's from these cords that the big named nerves finally branch off to run down the arm nerves, like the median, ulnar, radial.
Right. The ones we actually hear about more often. Okay, structure mapped. Now the consequences. You mentioned injuries high up can be devastating. Let's talk about those three major brachial plexus injury types.
Okay, so the worst case scenario is a complete injury, sometimes called a panplexus palsy. If everything gets damaged, all the roots or all the trunks you lose function in the entire arm and hand. It just hangs there completely paralyzed. Clinically, we call that a flail limb.
Wow, okay, that's severe. What about more localized damage, like Erb's injury? That sounds familiar.
Erb's palsy is much more common, yeah. It specifically hits the upper parts of the plexus, mainly the C5 and C6 roots, or the upper trunk.
Okay.
This typically happens when there's a forceful stretch between the shoulder and the neck. Think a bad fall onto the shoulder, or sometimes during a difficult childbirth, because C5 and C6 control key shoulder and elbow muscles.
Like lifting the arm and bending the elbow.
Exactly. So when you lose those, the arm hangs down, rotated inwards, elbow straight, wrist bent. It's called the waiter's tip position.
Like they're subtly asking for a tip behind their back. Very visual.
And the opposite end, Klumpke's injury. Klumpke's affects the lower part C8 and T1, or the lower trunk. This usually happens from forceful upward pulling of the arm, widening the angle between the arm and the chest, like grabbing a branch while falling. Since C8 and T1 are crucial for the small muscles inside the hand.
The ones for fine motor control?
Precisely. Losing them results in a complete claw hand deformity. All fingers are clawed. These injuries really show how knowing the anatomy lets you predict the specific functional loss.
Okay, we've mapped the main switchboard. Now let's trace some of those final power lines running the show, especially for the hand. Let's start with the musculocutaneous nerve. Where does that fit in?
Right, the musculocutaneous nerve, it comes off the lateral cord, mainly carrying fibers from C5, C6, and C7. Its main job is flexing the elbow. It has a pretty unique path. It actually pierces right through a muscle called coracobrachialis to exit the armpit area. Then it runs down between your biceps and brachialis muscles, supplying all three.
So it's the powerhouse for bending your elbow.
Pretty much, yeah. If you want to test its integrity quickly, you just check the biceps reflex. Tap the tendon, see if the biceps jumps. After doing its motor job, it continues down to the sensory nerve for the side of the forearm.
Okay. Now the two big names often discussed together, the median and ulnar nerves. Let's tackle the median nerve first. Sounds important for hand function.
Extremely important. The median nerve actually gets contributions from both the medial and lateral cords. So its roots are C6, 7, 8, and T1. Sometimes even C5 fibers hitch a ride. It runs down the arm, often near the big brachial artery. And here's a really key point the sources emphasize. Both the median and the ulnar nerve give off NO branches in the upper arm. None at all.
Wait, really? They just pass straight through the whole upper arm without connecting to anything. Why is that so significant?
It's hugely significant clinically. It means if you injure, say, your humerus bone high up and maybe damage the median nerve there,
Yeah.
the muscles it controls down in the forearm and hand might actually be spared because their connections branch off lower down.
Ah, I see. It's like the wiring is insulated until it gets closer to where it's needed. So where does the median nerve start working?
Once it gets past the elbow, it usually dives between the two parts of the pronator teres muscle. Then it supplies most of the muscles on the front of your forearm, the flexors and pronators. But crucially, in the hand, it controls the thenar muscles. Those are the muscles at the base of your thumb that let you touch your thumb tip to your other fingertips opposition.
That thumb touching ability seems pretty vital.
It is. It's key for gripping, pinching, manipulating objects. The median nerve handles all the thenar muscles except one called adductor pollicis. It also supplies the first two lumbrical muscles in the hand.
And if you lose that function, If the median nerve is damaged,
then you get the characteristic apandiformity. The thumb lies flat in the plane of the palm. It can't swing out in a pose. You lose that fine dexterity. Think about trying to button a shirt or turn a key without using your thumb properly.
yeah, okay, that would be tough. And common causes for median nerve injury.
Well, the classic is carpal tunnel syndrome, where it gets squeezed at the wrist. But it can also be compressed higher up, near the elbow, which is called pronator teres syndrome.
Right. Okay, now onto its partner, the ulnar nerve. The one responsible for that singing funny bone pain.
That's the one. The ulnar nerve is the main continuation of the medial cord, primarily roots C8 and T1. It runs down the arm, sort of behind the scenes in the back compartment initially, and then passes directly behind that bony point on the inside of your elbow, the medial epicondyle.
Ah, that's why hitting your elbow there sends such a shock down your arm.
Exactly. The nerve is very superficial right against the bone there, making it quite vulnerable. Like the median nerve, it gives off no branches in the upper arm itself.
And its job, what does the ulnar nerve control?
In the forearm, it helps out with flexing the wrist, flexor carpial ulnaris, and flexing the fingers. It gets the medial half of the deep finger flexor digitorum profundus. But its main domain is the intrinsic muscles of the hand. Think fine control. It supplies all the hypothenar muscles, the fleshy part below the little finger, all the interosseous muscles between the finger bones, the adductor pollicis muscle, that thumb muscle the median didn't get, and the third and fourth lumbrical muscles.
Wow, so it really handles the intricate hand movements. What happens if the ulnar nerve is injured?
You get a partial claw hand. Because it controls those small muscles that balance the fingers, loss of the ulnar nerve leads to the ring and little fingers getting stuck. They're typically extended at the main knuckle, the MCP joint, but flexed at the finger joints, the IP joints. It looks like a partial claw.
And any specific causes mentioned?
Besides direct trauma at the elbow, the sources mention handlebar neuropathy. Yeah, apparently common in cyclists or motorcyclists who put prolonged pressure on the base of their palm where the nerve runs. Causes numbness, tingling, and eventually muscle weakness in the hand.
Okay, we've covered the nerves mainly handling flexion and fine hand control. Now let's shift to the back of the arm, the extensors. This brings us to the radial nerve, which sounds like a really major player.
Oh, it's huge. The radial nerve is the largest branch off the posterior cord, and it carries fibers from all the brachial plexus roots, C5, C6, C7, C8, and T1. Its primary job is motor control for all the extensor muscles. That means the triceps on the back of your arm for straightening the elbow, and all the muscles on the back of your forearm that lift your wrist and straighten your fingers.
So if the median and ulnar nerves help you grip and make a fist, the radial nerve lets you open your hand and lift it up.
Precisely. And damage to the radial nerve gives a very clear, unmistakable sign.
Which has?
Wrist drop and finger drop. You simply can't lift your hand or fingers up against gravity. The wrist hangs limp.
I can see how that would be incredibly disabling. Try picking up anything if your wrist just flops down.
Exactly. You need wrist extension to stabilize the hand for effective gripping. Without it, hand function is severely compromised.
Now, its pathway. You mentioned nerves can be vulnerable depending on their route. How about the radial nerve?
It's particularly vulnerable because it winds around the humerus bone quite tightly. It starts behind the main artery, then dips back and runs in a shallow groove on the bone called the spiral groove.
Spiral groove. Sounds like a risky place for a nerve to be.
It is. After it leaves that groove, it comes forward again near the elbow, pierces through a muscular wall, and eventually divides in the forearm. It splits into a deep branch, the posterior interosseous nerve, which is purely motor for the forearm extensors, and a superficial branch, the superficial radial nerve, which is purely sensory for the back of the hand.
Okay, the sources highlighted 4 specific danger zones for this nerve. Let's walk through them. Where's the highest risk?
Highest up is in the axilla, the armpit. This is where you get the classic crutch palsy from improper crutch use pressing up into the armpit, or the infamous Saturday night palsy.
Saturday night palsy. Tell me more.
It's when someone, often after maybe drinking too much, falls asleep with their arm slung over the hard back of a chair or bench. That prolonged compression on the radial nerve in the armpit cuts off its blood supply or directly squashes it, leading to wrist drop when they wake up. Often temporary, but can be permanent.
Wow. Okay, so armpit compression is one. What's next down the arm?
The second major spot is right in that spiral groove we mentioned. If you fractured the shaft of the humerus, the broken bone ends can easily sever or entrap the nerve right where it lies against the bone. Very common injury mechanism.
Makes sense. Trauma to the bone directly injures the nerve hugging it. What else?
Third, further down near the elbow, a fracture of the outer bony prominence, the lateral humeral epicondyle, can also damage the nerve as it passes nearby.
And the fourth spot?
Much lower down, near the wrist. Remember that sensory branch, the superficial radial nerve? It can be damaged by cuts, or even a fracture of the scaphoid bone in the wrist, near the base of the thumb in the area called the anatomical snuff box.
Okay, 4 key vulnerable points. Armpit, spiral groove, lateral elbow, and wrist snuff box. Got it. Now, about that sensory branch, you mentioned something interesting. Even if it's cut, the sensory loss isn't huge.
Yeah, it's quite curious. The superficial radial nerve is purely cutaneous, just skin sensation for the back of the hand, mostly thumb side. But if you lose it completely, the actual area of numbness is often surprisingly small, maybe just a coin-like area on the back of the web space between your thumb and index finger.
Why so small?
Because there's a lot of overlap. The sensory territories of the median and ulnar nerves on the hand spread out enough that they cover most of the area, compensating for the loss of the radial's patch.
Fascinating redundancy. Before we leave the upper limb, let's quickly revisit the posterior cord. The radial nerve is its biggest branch, but there's another important one, right? The axillary nerve.
Yes, the axillary nerve also branches off the posterior cord. It's crucial because it supplies the deltoid muscle, the big muscle capping your shoulder. It's also quite vulnerable, often injured during a shoulder dislocation or a fracture of the top part of the humerus, the surgical neck.
And the consequence of axillary nerve injury.
You get a drop shoulder, the contour of the shoulder flattens. And more functionally important, you lose the ability to lift your arms sideways, abduction, specifically in the range from about 15 degrees up to 90 degrees. That initial lift off the body is done by another muscle, but the main workhorse, the deltoid, is out.
All right, let's switch gears quickly and head down to the lower limb. We can't cover everything, but we have to talk about the biggest nerve in the body, the sciatic nerve.
Absolutely. The sciatic nerve is enormous. It's formed from spinal roots L4, L5, S1, S2, and S3, a huge contribution. It exits the pelvis through a large opening, the greater sciatic foramen, usually coming out just beneath the piriformis muscle in the buttock, that it runs all the way down the back of the thigh. Its main job initially is supplying the hamstrings, biceps femoris, semitendinosus, semimembranosus, and part of the adductor magnus muscle.
And it doesn't stay as one giant nerve all the way down, does it?
No. Usually in the lower third of the thigh, it divides into its 2 major terminal branches, the tibial nerve and the common peroneal nerve, also sometimes called the common fibular nerve.
Okay, tibial and common peroneal, where do they go?
The tibial nerve continues straight down the back of the leg, supplying the calf muscles, like gastrocnemius and soleus, the ones that let you point your toes or stand on tiptoe. It continues into the foot to supply most of the small foot muscles. The common peroneal nerve takes a different path. It wraps around the side near the head of the fibula bone, that bone on the outside of your lower leg. It then supplies the muscles in the anterior compartment of the leg, the ones that lift your foot and toes up, dorsiflexion.
And that spot where it wraps around the fibular head, is that another vulnerable point?
Extremely vulnerable.
Yeah.
Because it's so superficial there, right against the bone. Pressure, trauma, even tight casts can easily damage the common peroneal nerve.
And if that happens, what's the clinical sign?
The classic sign is foot drop, because you can't lift the front of your foot dorsiflex. The foot hangs down. To walk without tripping, patients often have to lift their knee unusually high, a characteristic gait called steppage gait.
Makes sense. So how do doctors quickly check if these nerves are working okay?
For the tibial nerve, there are a couple of simple tests. You can check the ankle jerk reflex, tapping. The Achilles tendon should make the foot point down, plantar flex. Or you can just ask the patient to stand on their tiptoes. If they can do that, the main calf muscles supplied by the tibial nerve are working.
And for the common peroneal nerve, the one that prevents foot drop.
You test its function directly, ask the patient to lift their foot up towards their shin, dorsiflex the ankle, and you provide some resistance against it. If they can do that strongly, the nerve is likely intact.
Simple bedside tests mapping directly to nerve function. Okay, one last point from the sources regarding the lower limb surgical risk.
Yeah, an interesting connection to heart surgery. Sometimes surgeons need a vein to use as a graft for coronary artery bypass, and they often harvest the saphenous vein from the leg. There are two main saphenous veins. Harvesting the great saphenous vein, which runs up the inner side of the leg, puts the saphenous nerve at risk. It's a sensory nerve for the inner leg and foot. Harvesting the short saphenous vein on the outer back aspect of the calf risks injuring the sural nerve, which provides sensation to the outer foot and ankle.
So even in a completely different procedure, surgeons have to be acutely aware of this nerve anatomy to avoid causing numbness or pain down the line.
Exactly. It's all interconnected. Hashtag tag outro.
Wow. What a journey through the body's wiring. It really is an incredible deep dive, seeing how predictable injuries can be if you understand the structure. We started with that systematic breakdown of the brachial plexus roots, trunks, divisions, cords, RTCC5 down to T1, and saw how damage, depending on the level, leads to those really distinct outcomes. The waiter's tip from an Erb's palsy, the claw hand from Klumpke's, or the APAN from a median nerve issue, wrist drop from radial, it all maps back.
It really does. And, thinking about this, especially that point about the radial nerve sensory loss, we talked about how losing that nerve might only cause numbness in a tiny coin-like area because other nerves overlap and compensate. It makes you wonder, doesn't it? Given how vital these nerves are for both movement and feeling, what does this incredible redundancy tell us about how the body's sensory map is built? There seems to be so much backup, so much overlap engineered into the system. It's quite remarkable when you stop to think about the precision needed, yet the resilience built in.
That's a fantastic point to ponder. The resilience alongside the specificity, it suggests a really robust design. Well, thank you for sharing the insights from your sources and guiding us through this complex but fascinating territory. And thank you for joining us on this deep dive into the wiring of the human machine. Until next time.